It's with great pleasure that I introduce Dr. David Winchester, who's one of the most eminent surgical oncologists in the world. Dave has a long background in surgical oncology, had worked at the North Shore University Health System in Chicago, and some years ago was recruited by the American College of Surgeons, Dave Hoyt, Executive Director, to head the cancer programs. And Dave, being in charge of all of the cancer programs for the American College of Surgeons within the Division of Research Optimal Patient Care, also is the Medical Director of the Commission on Cancer, is one of his many responsibilities. And this morning he's going to talk about the new National Accreditation Program for Rectal Cancer, the 2017 launch of that program, as well as outline some of the other quality initiatives in the American College of Surgeons. So, Dave, all yours.
Thank you very much, Steve, and thank you for the invitation. It's a pleasure to be back here at the Cleveland Clinic in Weston, a second visit here. And today I do want to spend a little bit of time before we get into specifically the rectal cancer program to talk about the quality programs of the American College of Surgeons. So I hope this morning in the fairly short amount of time we have to outline the accreditation principles of the College of Surgeons. This is one of the main programs of the college. I'm going to cite the evidence that supports the establishment of the NAPRC, and then understand the basic standards required for accreditation by the college. So as you can see from this slide, we've been at this for quite a while. But the college was founded in 1913, and the Joint Commission back in the minimum standards for hospitals was back in 1917. That became the Joint Commission in 1951. Interestingly, the Commission on Cancer is the earliest clinical program of the college. It goes way back to 1922. Committee on Trauma followed in 1950. The HACC, the staging group in 59. The NCDB in 1988. We put that together then, which now contains about 200 clinical information points on approximately 34 million patients. It's really the world's largest clinical database. The ACOSOG has come and gone, but now is part of the Alliance. A lot of seminal work came from that clinical trials group. NSQIP has really escalated in recent years. The bariatrics program in 2005, the NAPBC, the breast program, the breast specific program is actually 2008. And now we're looking at the NAPRC and an oncology medical home. You might say, what's the American College of Surgeons doing, sticking their nose in medical oncology? Well, they actually came to us because they were establishing the oncology medical home, and we're looking for experts in accreditation. So we're now collaborating with the COA, that's a group of the medical oncologists, and another group, and we're going to launch that program this year. So these are the quality programs of the college. I didn't mention the children's surgery verification. That's one of the newer ones, which is starting, but I've mentioned all the others. So the mission of the commission is, and again, we're a consortium. We're not just surgeons. We're everything that's cancer. All the professional organizations. We have about 56 member organizations now, a lot of staff and volunteers, and we really are looking to improving survival and quality of life. We're doing that through standard setting, prevention, education, research, and the monitoring of care. The basic tenets of the accreditation program is, first of all, do we need an accreditation program? And we looked long and hard at this when we do this, because it takes about 2 years to 3 years to establish a well-organized accreditation program. So with the standards for this particular slide, it shows the COC standards, but it applies to all the accreditation programs, site-specific. You want to make certain the next step that the proper infrastructure is there, the right people are there, the right dedication is there to doing this. You want to have a database, and then you want to be able to subject yourself to a periodic, usually every 3-year, on-site review by trained surveyors. So for the Commission on Cancer, we really standard manual about every 5 years, and this most recent iteration is really focused on patient-centered care throughout the full spectrum of care of the cancer patient, from prevention all the way through end-of-life care. Psychosocial and palliative care have been added along with targeted navigation. As you all well know, when a cancer patient comes into a complex system like yours or others, they need help to be navigated from one point to another, see different services. Psychosocial distress screening is another new added standard. So we have about 1,500 COC accredited cancer programs in the United States. You see the distribution there geographically. We finally got that one up there in that state. That's a start. So the program standards manual now, the most recent one is, as I said, is patient-centered care manual. In 2016, it came out just last year. It has 5 main chapters: program management, logistics, clinical service, continuum of care, outcomes, and data, of course, data quality. You have to have 12 eligibility requirements met, and there are about 34 standards. We do have a commendation system for centers that excel and go beyond the standards that are established there. And the survey process, I already mentioned to you that that's an on-site survey, and goes through an application and goes through an on-site visit. And it's quite intensive and has been very successful. We've been doing this for a long time. But right now we're in the process of revising it because when you go and visit 400 or 500 centers per year, you begin to learn feedback that, why are you asking me about this? Why do you require this standard? Does that really contribute to quality of care for cancer patients? So we're taking that all into account now and revising our process. So beyond the Commission on Cancer, which I've just discussed, the NAPBC, again, established in late 2008. We now have 650 programs with 5 international programs, and that's growing, most recently in South Africa. The OMH program I mentioned, there are just 10 of those, and that's a program in progress. I think that will probably end up somewhere in the range of 200 to 300 centers in the United States. Trauma program, 650 to 800, depending on how you count. They've been around for a long time. NISQIP, nearly 800. And then the bariatric program, about 800. So you can see the American College of Surgeons is very serious about the quality programs, and we believe that quality is manifested through establishing standards and having a survey process in place. So you add those up, it comes up to about over 4,000 accreditation programs. As you can imagine, we have a lot of staff at the college that are devoted to that. 5 out of 6 of our programs have databases. The one is in progress. As I said in the 4 tenets there, you do have to have a database. You need to establish that you are meeting the standards and document that in a database.
Okay. Do you know in which programs main campus participates from what Dr. Winchester's outlined for trauma and MBS QIP and breast cancer and the like?
I know we're in breast cancer and bariatrics for sure. I'm not sure about the trauma. Obviously, I don't think trauma is not a trauma program. No.
And NISQIP?
Yes.
Yeah, so if I just had for programs who may not be involved, I'm just curious what you, on the staff level, perceive as value from the college for these programs. You know, why join? Why participate and get accredited?
I think there's a couple things. Obviously, the quality of the program, it makes sure that we're doing the right thing, and we're doing the right thing for the patients, and we're providing quality care. Then also there's a bit of a reputation for this, and it's a marketing thing for our patients. And it just kind of lets us and our affiliates know that we're doing the right thing. There's an accountability.
Okay, but Dave came up with some questions here, kind of MOC questions, if you will, and we want to address them. So which of the following is not an essential operational step for ACS program accreditation?
Probably C. I don't think you have to be an academic medical center.
Correct.
So maybe, Dave, you want to talk about that a little bit, 100%. The composition of the program? Yeah, maybe Dr. Winchester can address the, yes, you're back. You get your MOC credit there, man.
You do, yeah.
Awesome.
No, this is it's an inclusive program. You know, in our 1,500 accredited programs in a commission, 1,000 of those 1,500 are community-based, and that's where the action is. If you really look at the statistics on cancer care, I mean, Cleveland Clinic and other major centers like this are terribly important, but a lot of the cancer care occurs in 2/3 of our programs at the community level. So that's why you don't have to be an affiliate of an academic medical center to to qualify for accreditation.
You know, maybe towards that end, because I've occasionally been asked, what about COP, and what is the COP program, and how does that relate? You've got state chairs in cancer, and if you could just explain that a little bit to people, how structurally the COC is organized.
Well, COP is a different program. It's actually changed now. It's not called COP anymore. I don't even remember what it's called now, but it changes its name every year or two. COP and COC are really not in the same category.
The community-based programs and the state chairs?
COP falls within the NCI stratification and classification of centers. And of course, the most comprehensive are the comprehensive NCI designated centers. COPs are done at the more local level, but they have to meet the standards of the NCI.
Okay, and then what about the state involvement? When we have our advocacy meetings, leadership and advocacy in the spring, there's a lot of state chairs there.
Yeah, the Washington office of the American College of Surgeons now is the epicenter for those advocacy activities. And as you say, there's a big meeting every year. This May is another example of that.
So, I mean, that's part of the college effort, not only in ensuring quality from the physician end, but also from the patient end. So there's a large advocacy effort, and I think you mentioned that the 56 groups comprise the COC aren't just surgeons. Maybe just tell us who a few of those groups are, and not everybody, maybe some of the non-medical groups, for example.
Yeah, but obviously it's the same as the MDT of the rectal cancer program. The medical oncologist, the radiation oncologist, pathologist, the radiologist, all the specialists, the SSO, the gynecologist, the gynecologic oncologist. I mean, you can, anybody that has anything to do with cancer, including advocacy, and groups that advocate for cancer are part of the commission.
Like Livestrong or Susan Comins, or
yeah, right.
Groups like that. So I think it's a very inclusive group, again, to the point that it's not just academic medical centers, it's also not just physicians, it's
right.
Other people. So why don't you do a couple more?
This is a real picky-unish slide, so I usually try and pick one that people can't get right. But I just told you the answer a few minutes ago.
So who's awake here? Pick on one of our own people?
A, B, C, or D? How many programs do we have? Josh, you got that memorized?
Afraid not.
Take a stab at it.
I'll go with B.
Close. C. That's 4,400. We're going to work up to 5,300 eventually, but not there yet.
So a very big impact.
So where did the rectal cancer movement come from? The Oestrogen group, the optimal surgical treatment for rectal cancer, and I'll tell you a little bit more about that, actually came to us at the college, much in the way the medical oncologists came to us about an accreditation program, and in this case, of course, for rectal cancer. And we really regarded this as a really great collaboration between the clinical and accreditation expertise. We are experts in accreditation, not that we don't know some clinical medicine, we do, and we're pretty good at that. But the Oestrogen group, of course, is very facile and knowledgeable about rectal cancer evaluation and management. So Oestrogen, if you don't know about it, was founded fairly recently, about 5-6 years ago, in Cleveland, and they're constituted to improve the quality of rectal cancer care through the things mentioned there. And their goal was to create a multidisciplinary team-based national rectal cancer program so that there could be high-quality rectal cancer care for all Americans, not just those that live in Weston, Florida, or Johns Hopkins, etc., Mass General. So there are over 200 centers now in Oestrogen that are representing all facets of the U.S. healthcare delivery system that you see here, quite diverse, and there's broad representation, as you can see on the right, of the major professional organizations that are part of the Oestrogen group. So how did this evolve, and how do we make a case for doing an ARC here in the United States? To do that, we had to look at the European experience and then our own experience here in the United States. So there were about seven or eight countries that embarked upon really a regionalization of rectal cancer care evaluation and management, going from many centers to very few, not very few, but a fewer lower number centers around the European area. So they really introduced a population-based rectal cancer registry system. You do need data to analyze and generalize the trial information that's generated. They standardize care with respect to staging by radiology. That was all over the map with respect, as you can well imagine, to the quality of imaging with MRI or ultrasound. Neoadjuvant therapy was standardized. The surgical technique as well was also quite heterogeneous, and that was standardized. And importantly, the pathologic evaluation here of specimens was crucial. So they centralized the care for rectal cancer surgery, and this improved clinical trial accrual and improved monitoring of the standards and the outcomes. So the Norwegian project was initially planned for only 6 years, and it's still up and running, as are the others. And it really does make for a great platform for expansion of the program, uptake by other countries, as I illustrated earlier. And the implementation of total nasal rectal excision and the multidisciplinary team concept, focused care, has really altered rectal cancer outcomes. And most importantly, lowering the rates of local recurrence, lowering the incidence of permanent stomas, more patients receiving evidence-based care with guidelines, as I said, better recruitment to trials, and monitoring of standards and outcomes. So, interestingly, rectal cancer outcomes in Europe now exceed those for colon cancer. You think back to the Miles days about the outcomes then and the local recurrence rate and the deaths from rectal cancer earlier in the 19th century, and now look at it and compare it to colon cancer, which I think most of us would agree is less complex in its management. Not always, but most of the time. That's really remarkable. So in their arena, the real changes have been made internationally through clinical engagement from the start. This wasn't a bunch of bureaucrats and hospital administrators. I don't have anything against them. They're fine. This was clinical engagement right from the get-go, and looking at outcomes and benefits of doing this. So most of this evidence comes from Europe, and interestingly, that's commonly a single payer system, but not all. And now in the United States, of course, I don't know where we're going to go with that, but it's certainly not a single payer system. Single payer systems do make standard setting easier and faster, as you might imagine, but it doesn't mean it's impossible. So this is, I think, a David Dietz slide that the ostrich sticking his head underground. Do we have a problem with rectal cancer care in the United States? I just showed you the European experience. So how experienced is a typical United States rectal cancer hospital? And the answer is not very. About 70% of hospitals treat fewer than 20 patients per year. Only about 30% are high volume by common definition, and only about 6% of hospitals treat more than 50 patients a year for rectal cancer. You see in the chart there the distribution, so it's quite varied. So most U.S. rectal cancer patients are treated by non-specialist providers in low-volume hospitals. We've got a group of 5 or 6 trainees here now who are going to be going here and there to lead the way in expertise in care of rectal cancer. But that's 5 or 6, and there are many more general surgeons, and I'm a general surgeon, but a surgical oncologist. General surgeons do very good work. When it comes to rectal cancer and some of the low-lying rectal cancers, that's a real challenge to manage that. And certainly the kind of training that you're going through here now through your fellowship is going to put you in the leadership role for managing this disease. The rates for permanent colostomy in the country, in the United States, are variable, and they're excessively high compared to Europe. And there really hasn't been good standard setting guidelines and adherence to those guidelines for neoadjuvant therapy. The rates of circumferential resection margin positivity, which is certainly a surrogate marker for poor oncologic outcomes in rectal cancer patients, are high. The U.S. oncologic outcomes are inferior to the European countries that have instituted these national programs that I described to you. Here you see the positive CRM rates in the USA versus Europe overall. 17% in the United States, up to 21% for abdominal peritoneal resection. Lyon 3%, Germans around 3%, the Dutch. You see all the others there are significantly less with positive circumferential resection margins. This, just to remind you of what is the mesorectum, the mucosa, submucosa, and the muscularis, down to the levators there that you see. This is Mariana Burho's slide, and it just shows the anatomy that you, I'm sure, are familiar with, but it's not quite so clear when you're down in the pelvis doing this in the operating room. But that's the principle that you have to follow diagrammatically for making sure that you're doing a good total mesorectal excision. So the status of the National Accreditation Program for Rectal Cancer as of today. Again, this is a how many? We've been doing this now for at least a year and a half.
May 2014.
That's a long time. May
2014.
I lose track of time. May of 2014. It goes back to our original steering committee meetings where we began to talk about, do we need this? Let's look at the evidence and let's start working on some standards. And right now I would say we're in the final version of the standards manual, finally. It's gone through I don't know how many iterations, but that's the way it goes with accreditation programs. You can't just sit down and bang these things out and get going a week later. It takes a lot of time and a lot of input. The 6 pilot surveys that we did included this center and the Cleveland Clinic in Cleveland. You can see Baylor, Dallas, Rochester, the John Muir Cancer Institute in California, and then the center in Orlando, Florida. Our standards manual, as I said, now is in its final form, and it's not quite as long as the COC, which involves broader cancer types, but the 21 standards, again, you have to have the program management well defined, the clinical services, the quality improvement, and then we now have 11 performance measures for rectal cancer. So we decided right at the get-go for this particular program, in order to be eligible for NAPRC accreditation, you had to be Commission on Cancer accredited. We thought that it was necessary to have the fundamental infrastructure and commitment in place before we went to the rectal cancer. We did not do that with the breast program. I think we're going to probably do that now prospectively, but we have 650 centers now for breast cancer, and about 96% of those breast centers are also Commission on Cancer accredited. So it's pretty unusual not to have both accreditations. So one of these days we're going to be doing surveys that are comparable to the Joint Commission. I mean, look at the long list of accreditation programs. We're going to be sending probably a team, and then we're going to make it kind of like 2 or 3 or 4 days. We're going to consolidate these surveys, and we're also going to do some pricing that's fair based on that. So the MDT, as I mentioned, is essential here, obviously with the surgeon, medical and radiation oncologist, the pathologist, and the radiologist. Not that the others aren't important, that they're in our standards. We're talking about coordinators, we're talking about the administrators, and we're talking about psychosocial services. I mean, the whole team is important, but this is the MDT. Does anybody have to do anything to be declared a team member, the MDT of an accredited rectal cancer center? And the answer is yes. Interestingly, the medical oncologists are not listed here because they're forever doing protocols, and I don't know what we could do to train them. The point is, they were raised that way. They were raised with protocols. They were raised with this sort of mentality, whereas we are now, but we weren't then. At any rate, the surgeons do have to complete a training course that's being developed by the American Society of Colorectal Surgeons. I would think the pass rate for that's going to be quite high, and you can do it any time in the 3-year accreditation cycle. You're surveyed every 3 years, any time in that 3-year period of time. The same thing with the pathologist and the radiologist. When we put that out there to them, they, as you can imagine, that's when politics start. This got quite political about who's going to own that, who's going to charge for this or that, and so we finally have come to an agreement that the pathologists already have a well-defined protocol, step by step, for what to do for rectal cancer specimen processing and then the final reports. They've already done that. So what they have to do now is to say that, yes, I've read this. It's about a 5-page document. It's really very well done. Got everything in it. And we just have a simple attestation statement from the college that have reviewed this. So, it's trust, but our experience is that they know what they're doing. I mean, they really do, and they do a good job. The radiologists are likewise have a well-defined protocol for evaluating rectal cancer. Ultrasound used to be the mainstay, and it's not anymore. It's MRI, obviously. And the protocol at the Toronto, I think, has been accepted by the American College of Radiology as a prototypical, very well done protocol to follow. The steps to follow, the technology to follow, a lot of technology in that document. So that's also their part of their training. So yeah, those 3 specialists are stepping up to the plate and making sure that they're up to date. And to be up to date, things change. You're probably not familiar with RQRS. That's a rapid quality reporting system of the National Cancer Database. And that'll be the database for the rectal cancer program. The advantage of the RQRS is it's almost real time, rather than taking the 18 to 24 months for the NCDB to get the data in and then process it and send reports out. But remember, as you well know, cancer is not like some other diseases or like trauma. It's you look at the continuum of care, it may be a year or more before everything's done. So you can't really complete the data until it's done. And then standardized MRI reports and pathology reports. Good example here of the MRI for rectal cancer with a node there that you see, and the pathologic correlate showing a positive lymph node. That slide comes from Gina Brown. Now this is a good picture of a complete mesorectal excision. There's no defects in that specimen. The section has been clean and complete. And a fixed specimen, a coronal section, shows that, you did get around it. There's a nice complete mesorectum. The deep tumor is very close to the circumferential resection margin, but in fact it is microscopically clear. So, questions, Mr. Moderator?
Okay, so I guess we should probably pick on somebody here. I don't feel right picking on people in other centers with these questions. So I don't know. Aaron, how about we ask Dr. Rickles, who first authored one of our ostrich publications.
Which of the following is not a required member of the NAPRC multidisciplinary team? The surgeon is, the pathologist is, medical oncologist is, but the patient navigator is not.
They're important, but they're not part of the MDT. Correct.
Okay, this one's a little bit more challenging. We'll maybe move down the table here. Feel free at other centers to volunteer, but I'm not going to insist. We'll stay in the room here for the questions. Then I am going to turn to some other centers for a couple of other questions. If anybody has questions, ask them, but maybe Dr. Hiller can tackle this one here.
The public magnetic resonance imaging standard in the NAPRC applies to all except the following. It's A, the reporting radiologist must be a member of the rectal cancer MDT. That's true. MRI report format is determined by the institution's radiology department. That is not true. That's the except. It's been standardized now.
Yeah, so that originally came from Gina Brown. It was adopted locally by the University of Toronto. What I'd like to do is go to a center like maybe I saw Mike Maron at Hopkins, and Mike Marone at Hopkins, if we go to Johns Hopkins. Because when we designed the group, the ostrich group, and you mentioned it, Dave, and the standards even say it, the standards say the person to be included is a surgeon. It's a surgeon, it's not a colorectal surgeon. That was very deliberate. You mentioned that too, about being inclusive, the way the COC is inclusive. You know, the program is not yet launched. How do you guys function there at Hopkins in terms of your MDT? How often do you meet? Who's required to come? Do you discuss all cases? Do you discuss select cases? synoptic reports. Just tell us a little bit about how it exists today and whether that's changed as a result of knowing the program is online.
Well, first let me just comment and applaud Dave Winchester for his more than 20 years of great work. He way predates even Dave Hoyt with his work with the COC. He also mentioned a couple slides back some of the controversies in the political treacherous areas, and ironically, I'm not sure that Hopkins is a member of the COC. I know NIH or NCI wasn't for years and years, and I know Hopkins wasn't for years and years. So if that's a prerequisite, that is an interesting hurdle to cover. Bashar, I don't know whether you want to comment about some of the other issues.
So, can you hear me?
Yeah.
Good morning, everyone. So we're not in the infancy of this sort of project for at Hopkins. We started our multidisciplinary rectal cancer meetings or clinic about a couple of months ago, and essentially we have a clinic on a specific day. After we bring the patients, we all get together, surgeon, medical oncologist, radiation oncologist, pathologist, and the radiologist. And we discussed every single patient. And we're putting all our rectal cancer patients through this clinic. Now, this is only 2 months in the making, so I can't tell you too much about it. We don't have a database established yet, and we were very much interested in getting accredited. So that's why we would like to see what the standards are and what we need to do to get there. This was an initial step that we had to take because prior to this, we had a tumor board that we would present all select patients. You know, the tumor board was held on a different day, and it still goes on. Okay. We present colon cancer, you know, tough cases that come through, but not specific for rectal cancer. So for rectal cancer, we just started our multidisciplinary approach to this, and it's worked out very well so far. You know, every patient that comes in with a diagnosis of rectal cancer, we put them in that clinic. We haven't really started talking about too many follow-ups, and as I said, it's only been 2 months, so we actually haven't had probably a single operation yet out of that clinic because the patients are still undergoing radiation and, you know, various sort of approaches to the plan. So we really would hope to be accredited soon. We really hope to get up to the standards that you guys have just mentioned very soon, and we have a lot of these things in place, but not everything. So far, it's only been, I mean, I know Mike probably might want to comment, you know, this has been for the colorectal group at Hopkins, so not surgical oncologists are not involved in this, and no general surgeons are involved in this. You know, the rectal cancer's multidisciplinary clinic has been sort of mostly focused or on and by us. And it's worked out well. You know, Hopkins is an interesting place. You know, before many years ago, or up until recently, the surgical oncologist did a lot of the rectal cancer, and now mostly it's done by the colorectal surgeons. You know, especially the rectal cancer. I'm not talking about colon, but especially the rectal cancer.
Yeah. So, and just to add, the infrastructure of like the MR reporting, the synoptic reports out of pathology, as you alluded to, that's pretty well standardized. But the group has not embraced the inclusive piece, in part that's because we're a tertiary referral center. So it'll be interesting to see how this evolves and other centers evolve with it.
I just make the important point to you and all the others too that you can't really know about what you have to do for the NAPRC until you see the standards manual.
Yeah, it's interesting to hear the perspective from Bashar and Mike in terms of Hopkins, you know, one of the world's leading medical centers, but not COC accredited yet. But here's an impetus to become COC accredited, to become rectal cancer accredited, and even knowing that the program is in the offing, how you've changed your practice. Prior to the site surveys, when the Oestrogen group got together in 2011, we did a survey amongst ourselves, the original 16 groups, of which you guys were one of the groups. I think John Efron was your representative. And the majority of centers did not discuss every patient, did not meet weekly, did not have all of those people in attendance. So, you know, even the nucleus of centers, if you will, all changed as a result of the program. But I want to go to another setting because we're talking about different programs and different settings.
Importantly, there have to be performance measures to see how well you're doing. And again, there are 3 types of performance measures. The accountability measures are the highest level of evidence, so based on clinical trial information. Surveillance and quality improvement are the three major types of quality improvement. So the accountable ones are the involved distal resection margin rate and the mesorectal grade rate. That's how well you've done a complete circumferential resection margin. All the others there are very important. The leak rate, how often you have a permanent colostomy, how often you have to go back to the operating room. Interestingly, we've studied 30, you hear about 30-day mortality in surgery. That's sort of the standard. And we've looked at the 30 and 90-day mortality now for lots of different cancers. And we really need to start talking about 30 and 90-day mortalities because it can almost double between 30 and 90 days for mortality. The CRM rate we've talked about, the lymph node has been discussed extensively in the literature about how many lymph nodes you have to remove to feel like you're adequately staging the patient. Obviously, the local recurrence rate is markedly improved, and then the 3-year disease-free survival. So if in the future we want to finalize an electronic survey application form, we want to get this manual out that I mentioned. It's not mentioned here, but it should be. We want to make sure that's widely available. A lot of our COC surveyors are interested in becoming surveyors for this program, but we want to make sure that they're adequately informed about rectal cancer details, and so that'll be a rigorous process. Business plan, and we'll market the program and launch it, and it'll be in the next few months that we'll formally launch this because we're getting very close. So that completes my presentation. Thanks very much for your attention.
Thanks, Dave. Nobody's dialed in with any questions for Dave, but let me turn first to Winthrop University Hospital. I did see some people there a short while ago, and then we go back to main campus in Ohio. Yeah, good. You guys get the gold star for attendance today. For sure. So I'm curious if you can tell us what your thoughts are about the program and what you knew about it before today, and if you've learned from it today, how it might, how it grabs you. Is it something in which you'd be interested? I'm trying to pick on you deliberately because a lot of the other programs have been in the ostrich group initially and participated to some degree. So I'm curious what your thoughts are.
So this is Colin Brathwaite. We have a strong interest in the program, and in fact, we're in the process of discussing it now, how we structure the program, and I had a keen interest in hearing what the requirements are. We're always concerned that in surgery, many times we create clubs which become exclusive and keep people out. And one of the concerns I had was whether there was going to be a requirement that the surgeon be a colorectal surgeon, and it doesn't seem to be that way. But I think we have a very strong interest in this, and we'll be planning to apply and participate. I also have a comment from Dr. Marina, who recently joined our faculty here. Corrado, Marina.
I have a comment regarding the sample population that is going to be required to look at comparative analysis and trending for the institution. How many cases expect they are needed for an institution to see how they're doing and how do they compare to the benchmark? How many cases?
That's a question that we've discussed extensively by the steering committee, and setting specific numbers is a dangerous business because then you talk about inclusive and exclusive. If you have, let's say, 10 or 12 or 15 cases per year, and you meet all the standards, and that's been verified, and you can show the data that you're doing what you're supposed to be doing, that's fine. If you do 150 a year, that's another matter. But is the 150, if you're the patient, are you going to go to the 150 center or the per year or the 12 to 15? Well, the research we've done shows that patients stay local in general. They don't have the means to travel long distances. So the numbers game is kind of tricky.
Okay. I want to follow up with the expected decay in performance as it relates to volume. Isn't there a correlation between the volume and the compliance with the standards?
That is true for about 8 cancers, where we can see a volume outcome, and I think rectal cancer is probably going to fall within that. But Steve, tell me what number you think is required.
When we surveyed our COC centers who were interested, because separate from the Oestrogen initiative, we did a survey through the COC, and we found that there was a break point of around 20. The centers who were actually interested did a minimum of 20 cases a year, and the centers who were doing less than that seemed not interested in the programs. That's kind of a natural break point. Now, that doesn't say what their results are, but that does correlate fairly well with what's been seen in the literature at about 20 cases a year. Less than that being more likely to be problematic, more than that more likely to be well done. But remember that part of the reason for it being well done is it's a team initiative. So by appropriately staging with MRI and using the Toronto protocol, you know when you need to give neoadjuvant therapy, and the neoadjuvant therapy is given because of a threatened margin, and you're more likely then to have a clear margin. So when the standards are assessed and the surveillance metrics are analyzed, that center with the team going through all the steps ends up looking better because there's a lower incidence of CRM positivity. In addition, because you're looking at the coronal sections on the screen post-op in every patient, and you're looking at the whole specimen, you're more likely as a surgeon to be very meticulous with your technique because you know everyone in your hospital is going to see your work product and you want to have a complete TME. So it's the team driving the effort, and I think that's the point. And again, to emphasize, it's the team of whoever is there. You do not need to be board certified by the American Board of Colorectal Surgeons. Okay, that is not a requirement. The requirement is that you're able to meet the standards as a surgeon producing quality specimen TMEs.
So
And the pathologist and radiologist.
From the standpoint of basic quality efforts, do you see the expansion of this approach to certain index oncologic cases, such as esophagus, pancreas, and so forth?
Yeah, that's a question that's a societal question, a professional question for professional societies, and how far do we go with the accreditation program? There are 8 complex cancers. You've mentioned 2 or 3 of them. Bladder cancer is another one. Pancreas, total gastrectomy, esophagectomy, pneumonectomy. There are about 6 or 8. So it's we may be able to get into one called complex GI. The urology is a separate category, but I personally see as the future that evidence-based guidelines, accountability, standard setting, and demonstration that standards are being met is terribly important as we move forward in the management of our cancer patients. So yes, I think there will be more accreditation programs. The challenge there is to make it efficient and make it, because if you're going to be accountable and you're going to do all these surveys, you really need to be organized with respect to how to going about that. So it's a good question, and I'm not sure I can answer it thoroughly, but that's my own view on it at this point.
There's a question, Dave, from one of the hospitals, which is, so while coronal sectioning is standard in Europe, it's not been the standard in the U.S., and the CAP provides protocols for reporting but not processing. So will the CAP standard specify how the specimens need to be processed?
I believe the CAP has done that most recently with respect to how to process the specimen. Mariana would certainly agree with that.
Yeah, there's been a lot of work done by Mariana Barrow, Mary Kay Washington in that regard, as well as the Cancer Committee from CAP. I would add to that the COC will be housing photos as well, I'm told. So right. In addition to the educational manual, which Dr. Winchester discussed, whoever asked the question, the COC will house photos that are going to be provided by the CAP lead pathologist. So any pathologist who wants to say, I want to see a complete TME, an incomplete TME, a near complete TME, I want to see in coronal section the correlation to, like Dr. Winchester showed, the correlation to the MRI will be available, and part of that may also reemphasize the processing, how you get it to look like that, if that's the answer to that question. So Ohio, if we can go back, Matt Kalady, I saw Herman Kessler. Herman, I know we're a few minutes over, but none of the European centers dialed in. They're still enjoying the New Year's holiday. So I'm going to take you as our European in residence here, and Luca, of course, too, but I know that there's a lot of work done in Germany, particularly in Erlangen, where you were from, with Werner Hohenberger. And can you just describe a little bit about what was achieved in Germany by having this approach to rectal cancers?
Yes, especially in Erlangen, we conducted training courses. So it was done similarly like when Bill Heald went to Sweden to install the TME project. We did it the same way because we organized colorectal courses every year. Invited Torbjörn Holm to teach surgeons how to do extra-elevator APR. Bill Heald was operating, so all the leaders were invited, and these courses were very attractive. The surgeons could go to the OR, and I myself could assist these surgeons, so I had a lot of profit from that. But it was interesting to see your structure of the MDT because it's exactly the same one, which is the prerequisite in Germany too, because they developed these Darmzentren, and this means that the plan is that colon and rectal cancer should only be treated in certified bowel cancer centers in the future. And it has also a political implication because the insurances observe that, and in the future everybody may operate on colorectal cancer, but he may be not reimbursed entirely. So this is not the discussion here in the United States, but this is the discussion in Europe meanwhile. So it's very strict. And I was part of the certification team in Erlangen for the bowel cancer center, and there were very strict criteria. The pathologic criteria you mentioned were exactly the same ones, exactly the same. And the participants in the MDT were also exactly the same on the team. So I think it's a very positive initiative you're starting here. I think it's very good.
Any comments while we're in Ohio before we wrap up, Matt or Luca?
No, this is great. We've been very lucky to kind of help be at the forefront of this with you guys and some other centers. And I think we're up to date on our standards because we've helped develop them some with Dave Dietz when he was here. And I think it's the right thing to do. And it's a great process. And we're looking forward to getting it online.
All right. Well, I don't want to take up any more of anybody's time. We're about 10 minutes over, but I certainly want to thank Dr. Winchester for an outstanding presentation, helping update all of us where we stand in the National Accreditation Program for Rectal Cancer.